No worries.
Good evening, everyone. I'm just going to wait a minute while everybody gets online here. Okay, in the interest of time, I'm going to get started because we were respectful of everybody's time here. We want to be finished by 8. Welcome to today's session for the first 5 years community of practice. Happy New Year to everybody. Just a reminder, I'm Eleanor College. I'm a family physician. I'm the CPD program director at the DFCM. And my partner in crime is Dr. Ryan Bannock, who will introduce himself shortly. And I'm also introducing our speaker in just a moment. We wanted to just mention up front that actually we had some tech issues starting this webinar up. So if for some reason you get booted off, please check your email where you registered for. We'll give an update there if we have to reschedule or if we need to send you a different website or link. But hopefully so far we've been okay for the last 5 minutes. So hopefully everything will be okay for the next hour. Anyway, so today we're talking about working smarter, not harder, managing your inbox and paperwork. But I'd like to start with the next slide, which I believe is our land acknowledgement. So we just wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still a home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. Next slide, please. So just a reminder, if this is your first session with the first 5 years community of practice, this is designed for you. It's free, it's fun, it's full of answers. We try to make things very practical. We like to tap into the expertise of our speakers, but we also want you to share your own resources and knowledge on the chat if you have that opportunity. We like to make it fun by pairing it with a snack. Today is carrots and ranch dip. I think since I have less younger kids, I don't have as many baby carrots around, so I've had to resort to cucumber and hummus, but I highly recommend eating while watching. And then I already introduced myself. I'm moderating today. I'll turn things over to Dr. Ryan Bannock to introduce himself.
Hi there, I'm Ryan Bannock. I am the Family Medicine Early Career Supports Lead in the Office of Health Systems Partnership at U of T. I'm also the lead physician of the Norfinch Foe. I also do sit on the Section General Family Practice Tariff Committee, and I am the co-chair of the Northwestern Toronto Primary Care Network.
Thanks, Ryan. And actually, just back up one slide for a second, Marissa. I just wanted to mention that next month you will see our new co-chair, Dr. Melinda Caputo, who's going to be joining us, and she'll be working alongside Dr. Bannock. So we can't wait to welcome her in February. Next slide, please. So just a reminder, we don't have any financial disclosures to disclose here from the perspective of any forms of bias. However, we did want to acknowledge that our program is possible due to financial contributions from the Fidani Chair in Improvement and Innovation. So we're very grateful to that chair fund. And all of our program content was reviewed by the Scientific Planning Committee. Next slide, please. I'm just going to ask now introduce our panelist, Dr. Dan Pepe, and I'm going to ask Dan just to introduce himself and speak to any conflicts of interest you might have.
Yeah, thanks, Eleanor. It's good to be with you guys. I'm a family doctor from London, Ontario. My wife and I share a practice of 2,000 people plus in London at the London Lambeth Medical Clinic. I was the clinical lead in the Office of Health System Transformation. I am no longer the lead in that office, so I'm just a regular family doc. I think the only financial conflict of interest might be that we've gotten an InfoWay Connected Care Innovation Grant. So we're just doing some work to try and make life better for family docs. But that's it in a nutshell. I'm looking forward to tonight. It should be fun.
Thanks so much, Dan. Next slide, please. So Dan's introduced himself. Ryan already spoke to his conflicts. Myself, I get an honorarium for some OCFP work that I do, as well as a salary from the DFCM Quality and Innovation portfolio, and stipend for some work I do for the McMaster PBSG modules, none of which I believe poses any form of conflict for today. So next slide, please. So just a reminder, if you have any questions, please post them in the Q&A, and then we'll do them at the end of Dan's talk. And then certainly feel free to post your comments or share any resources or things that come to mind in the chat. Next slide, please. Great. I'm going to turn things over to Dan. Super excited to hear about your thoughts on managing our inbox and paperwork.
Yeah, it's not hard, right? Managing our inboxes. It's pretty easy. First of all, thank you to the 34 people who have taken time out on a Tuesday night to hang out with us for an hour. Whenever I give talks or whenever I've given talks, I hate giving a talk where the speaker just rambles through their slides and like is insistent on getting through the slides. So if there's something really interesting, if you have questions, interrupt, ask questions, put stuff in the chat, react, do whatever. I'll do my best to make it interesting because I know the thought about talking about an inbox for an hour is a little bit nauseating. But after 8 years of practice, I've thought about it 6 ways from Sunday, and I've kind of landed in a decent place inbox wise. So I don't know if they're totally proven, but they're proven for me, and I'll tell you why. Okay, let's go to the next slide. Okay, so habits. We talk about habits with our patients all day long. Eat better, exercise more, don't let your pills run out before you call for a refill. What else? There's so many. So there's a couple of areas I wanted to talk about today. One was schedule design. Another was lab results workflow. Another was delegation. Another is EMR optimization. And then what I would call the paperwork process. And I want to give you guys the confidence that you can actually do this. So maybe if you can share in the chat where you're practicing, how many people you're looking at, just some random stuff so I get some ideas. I can make sure that what I tell you is actually relevant for you because, yeah, 1,000. Okay, excellent. Thank you, Ryan. So the compound effect is really key. There's little small things that we do that we're probably not aware of that we do that either make our lives way easier or make our lives way harder. And so the concept of fewer retouches is really, really, really important because I found so much of my work was from going back and cleaning stuff up against Beaton, 1090, Midtown, 500. Excellent. You guys are awesome. Toronto, 950. Okay, this is great. Keep it coming. So this is what I'm hoping for engagement wise, because then we can actually have a good conversation about it. Okay, let's go to the next one. Okay, schedule design. So protecting the workflow. So the schedule really defines your life in a lot of ways because you book your schedule. My schedule typically, we work Monday, Tuesday, Thursday, Friday, and then Wednesday I'm in the OR surgical assisting. We do hip and knee replacements on Wednesday, so that's my day to not write any notes and just hang out with surgeons, which is kind of fun. I used to start my days at 8:30. I now start my days at 10:30, which probably sounds like sacrilege. This is awesome. Thanks, guys. If people want to tell me too, like what time do you start clinic or when you work, and that's also, I think, kind of interesting to find out just to see where everyone's working. And I'm going to explain to you why the heck I start at 10:30. So that sounds insane. It's like, well, how do you see people if you're starting at 10:30? But you need to do the later morning start, or you can do the later morning start because what it allows you to do is actually get ready for the day. So if you've got little kids and they're sick and the drop off gets messed up, you can help them. If your spouse is unwell or something's happening and their schedule is wrong, then you've got a little bit of time. And if everything goes well and perfect and the kids get dropped off or you do all your morning routine and you walk your dog, then you actually have 90 minutes before the first patient to actually start doing what I call shared triage, looking through the results, huddling with your team and getting ready. And it's that physician supported triage that makes a monstrous difference, because if you think about it, how does all the work come to your office? It comes to you by people calling and leaving messages, right? So when they call and leave messages, who's the first person to triage it? It's usually not a nurse. It's usually not a physician. It's usually a secretary. And at least in London, the secretaries tend to be paid $20 to $22 an hour, and they don't often have a lot of medical training. So you're putting the person with the least amount of medical training in the decision-making for who's coming and who's not coming. And the only tool we often give them is book an appointment. And then we wonder why our schedules get overwhelmed with booking appointments. So any questions about that initial statement? And you can just throw it in the chat or raise your hand or whatever's good. I see some people starting at 10 to 3, 9 to 5, 9:30. I like it. It looks like we're kind of 600 to 1700 with the biggest practice. 9 to 4. Thank you, Sarah. 8 to 4 focus practice. Yeah, I know, Preeni. I love the 10:30 start too. It's magical. They never tell you about that in medical school. And I didn't know either. Let's go to the next slide. Then if there's questions, we'll do that. Okay, so we've talked about the morning buffer. We've talked about the first patients, and you really want to clear that triage wave, because what happens is it's Monday morning, everyone calls, everyone. Oh my God, I'm so glad you're open. I've got all these issues. I need them all dealt with. And it's like you're trying to see people and then you're getting instant messages. We're on TELUS during that triage wave. And it is exhausting because you're trying to manage patients and deal with triage decisions at the same time. So it just helps to separate out the cognitive load a little bit. And then again, over lunch, you get that 90-minute protected break. So if you're falling behind, then you can spill into your lunch and still have a 60-minute lunch. You have the option to go home and exercise if you want. If that's an ability, you can go to the gym and work out a little bit. You can have a meeting, you can go see your spouse, you can check up on your kids, you can see what's going on, or you can just do some reading. Like if there's something that just gives you that rest, because I think one thing that I never realized as a family doctor is how cognitively heavy our work is. Like you see somebody, they bring up 5 issues. It's actually kind of exhausting to do that work. And you have to give yourself the space and pace to actually get through that. Okay, how are we doing time-wise? All right, let's keep going. We'll kind of hit the major points and then we'll have a discussion after. Okay, next slide. Okay, so we talked a little bit about the physician-supported triage. Don't let your staff guess. If you know that someone's had a cough for 3 weeks and you're going to order an x-ray anyways, just say, order an x-ray. Let's see if they've got pneumonia. Because if they don't have pneumonia, it's probably a post-viral cough, and you can probably manage that if you have a relationship with them and if there's nothing weird going on. The first call resolution is really key. We all know the patients who will call. I have a lady who's called me every day for the last 3 weeks about symptoms of a UTI. I've cultured her multiple times. It's not a UTI. It's lichen sclerosis that needs clobetasol. She can't apply the clobetasol, but she's also kind of in a palliative situation. And we have a phone call every day about this. And so my staff know not to hop on the phone with her, because that is a 25-minute call for my staff. It is a 5-minute call for me. And so we put the physician where I'm going to resolve the issue the best. And also there's sometimes where we see someone who calls and we go, that person should not have a visit in office because that will blow up our schedule. So we're going to do a house call instead. And we go out and do a house call. And I have the luxury of working with my spouse. She has the luxury of working with me because I can run clinic, and then she can go out and do a couple of house calls in between drop off and pick up with the kids, which is really helpful. So you want the schedule to create capacity. And when you have capacity, it's calming. Okay, let's go to the next slide. Okay. Anyone file reports through HRM and faxes and have to review all their results in the morning? So many, so painful. Yeah, it's really painful. So one thing that drove me insane about HRM is that you'd post the results in HRM and then you would have to go into TELUS. And as you go into TELUS, you then would have to enter each individual chart, open the thing again, figure out what's going on with it, and then do an action related to it. So if it's an x-ray, it's like, I see they got the x-ray, I post the x-ray shows they've got pneumonia, then I've got to make a comment in their chart and go through and do all the work. So one thing we've done in the office is I've actually started to employ ClinicLine. And ClinicLine is a remote company that brings in workers from the Philippines that will VPN into your system. And I've actually trained them to post my HRM results. So they don't interpret them, they don't do anything with the results, but they just literally move them from box A to box B, and then they copy and paste all the impression and plan of the text. So I can look at it quickly and actually get a sense of what the report is before I even go. So I haven't posted anything out of HRM for like, I don't know, 6-9 months. It's been amazing. And they charge $18 an hour. They don't take sick days because they will backfill. And so I can now tell Ontario MD that it costs me $90 a week to post my results out of HRM. And so that was a really useful thing that we did, because I realized a physician doesn't need to actually post a result. Anyone can post a result. We need to interpret the result and come up with a game plan. As we did that work for ClinicLine, we then came up with a number of what I would call SOPs, or standard operating procedures. So this is just how you manage stuff. For example, you get a mammogram result back, BI-RADS A, no masses. So what's the workflow? Normal person, standard mammogram, categorize their BI-RADS risk, set a reminder that they're going to get a mammogram again in 2 years, send them an email with the result saying, your mammogram was normal. It's reassuring. Here's a copy of result. All I need to do in that entire loop is look and say mammogram normal BI-RADS A. The rest of it is handled by my staff through delegation. What else do we got? That's just one example. There's more and we can get into them. Let's go to the next slide. We're tackling it all at 50,000 feet. Okay, so this is me just breaking down the remote clinical staff a little bit more. So the system input that comes through the remote clinical staff that are categorizing, they're extracting the key value. I am routing and reviewing. Then it's my clinical staff, so my nurse, my MOA, or my practice facilitator. And then once we've closed that out, that just gets archived. All right, let's do the next one. Yeah, perfect. Has anyone used Encounter Assistance in TELUS? I don't know what the equivalent in Acuro is. I'm sorry. I only work in one EMR, but I'd be curious to know if anyone has come across them. So I can probably show you guys only Encounter. So what I did, Eleanor, was I took the Encounter templates and I hijacked it a little bit. So yeah, I love the AI scribe. So what I do with the Encounter Assistant is I've made it a directive assistant. So when the remote staff see a result that comes back, let's say someone has an A1C between 6 and 6.4, so they're pre-diabetic. There's a little button where I click in the Encounter Assistant and I say pre-diabetes. So when they click that, if the patient, they don't see pre-diabetes listed in the CPP and they click it, it will code pre-diabetes for me. Then the second thing that happens is it says, send a message to the nurse. So they click that box and it sends a message in TELUS to my nurse to say, this person has a new diagnosis of prediabetes. So then my nurse knows to send the prediabetes email, which is an Ocean template. And that Ocean template says, I'm going to use you, Ryan, as an example. Hi, Ryan, your A1C is 6.4. This tells us you're at very high risk for diabetes. We would recommend that you reverse this immediately to avoid complications A, B, and C. And then we're going to recommend that you sign up for Lifestyle RX. Has anyone heard of Lifestyle RX? I hope so. Nope. Okay. Lifestyle RX is absolute money. Okay. Whoever has heard of it, put the link in the chat, because I think any patient in Ontario with prediabetes needs to be referred to Lifestyle RX. So it's 12 weeks of OHIP covered lifestyle coaching. They teach them about protein, they teach them about sleep, they teach them about exercise, and I have seen A1Cs be reversed many, many times. So we actually used Lifestyle RX as part of our workflow. So same goes if someone has a fatty liver diagnosis, they get referred to Lifestyle. Same if someone has dyslipidemia, they get referred to Lifestyle. And so we use this directive assistant to actually standardize the flow and processes. No outside use for flow. Yeah, it's the best. Thank you, Leonard. Okay, so there's a bunch more in the directive assistant. We can talk about it later, but let's go to the next slide for now. So these are my staff and team. So we talked about the remote clinical staff. So they're just tagging data and faxes. They're following a standard operating procedure. They're sending out normal messages. So let's say someone sends me a urine sample and there's no evidence of a UTI. I message Jenny, who's our remote staff, and I say, hey, Jenny, tell Bob he doesn't have a UTI. My practice facilitator is our master of paperwork and Ozempic forms and long-term care applications and all the things that you sort of do often, but don't do often enough. And they just kind of are annoying and cause friction. Amanda fills out the vast majority of that paperwork. And then again, we're put in the position where we can approve it, change it, modify it, and then she's making sure that it gets sent off, received, payment is collected, all of those pieces that we need. MOA and nursing support. So now that we've kind of upscoped our team and that not everyone is filing faxes during the day, after we do that phone call triage, my secretary, who would normally be on the phones all day, actually gets up and starts walking and grabbing patients and doing vital signs. And then my registered nurse, who used to do that job, now does not spend her day running back and forth. She's actually in the visits, helping with the well baby visits. She's doing vaccinations, immunizations, counseling people, on like basic wound care and stuff like that. And then we get to sit in the place of being the medical decision maker. So I'm going in after the baby's been measured and is ready, talking to the parents, seeing if they have questions, checking the baby. I message my nurse, we do the vaccines, I'm out. And then my nurse is in, she's talking with them, she's making sure the baby doesn't have a reaction. She's sending them a copy of the vaccines, giving them the information for the health unit, and I am done because my secretary then comes back and books them in for the next visit. And so we try to really limit, not in a bad way, but we want to make sure that we have my presence in the room or my wife's presence in the room when there's a high value part of the visit. So that's just a little bit of high level delegation. Let's go to the next slide. Okay, we talked about this already. These are just some examples of me actually looking through messages. So someone's like, I think I'm having a stroke. Call them and tell them to call 911. Someone says, I think I have a skin cancer on my head. It's really scratchy and itchy. Okay, double book them with this person and tell them it's a 5-minute cryotherapy visit. Someone was sick off work last week and just needs a note. I give that to my practice facilitator and she sends off the note. So the other interesting thing about triaging with your staff is they learn how you make decisions. And then they go, I think this person needs this. Is that right? Yes. And then it's like reinforcement learning. Okay, let's do the next slide. Okay, so these are just examples of things that you can do in the EMR. I'm pretty sure most people do this, but the only thing that I'm going to highlight is that inbox hygiene. So sometimes messages get sent like patient needs urine sample or patient called very angry and all these different things. Until there's actual message subject summaries. And then you can create distinct inboxes with those message subject summaries. So we have our critical box, our contact patient box, our office task box, our make referral box. And each of those gets filled with standard tags so that we know what's being done. It's just like good hygiene. You wouldn't throw your socks in every drawer in your cabinet. You would be like, here's the sock drawer and the shirt drawer and the pant drawer. This is the same, but in your EMR. Yeah. I think that's the key thing I want to cover here. We can talk more about it if there's questions, but let's go to the next slide to keep it moving. Okay, this is what my practice facilitator does on paperwork. So we have an email for the office. People can email the office. They can leave a voicemail. Amanda always calls them and finds out what's going on or emails them back and says, what do you need? What are the details? And she makes sure that it's appropriate for us first. So if there's someone else who's a better fit, we'll say, nope, that's for the audiologist, that's for the physiotherapist, that's for your chiropractor. Once we know that it's appropriate for us, we always collect payment first. So I've done that through Patient Serve, which is that program or that company that just got acquired by Well Health. I also have actually started to go back to just doing e-transfer with auto deposit. It actually seems to work the best with the least amount of friction. So I think I'm headed back there. And I'm probably going to move away from uninsured services because that just leads to more questions from patients. Again, the admin facilitator is going to help them pre-fill out all the non-clinical sections of the form. I'm going to review and sign it. And then once I've signed it, I just give it back to Amanda and I say, you track it, keep it in the flow, make sure the payment's all good. And I don't want to think about it anymore. Okay, let's go to the next slide. There you go. That is a high level summary. I think we wanted 10 minutes. And we're a little bit over that, but hopefully there's some good time for questions and discussion. So I'll stop talking now and start listening to you guys.
Great, thanks. Thanks so much, Dan. And yeah, I feel like you've really given us, all of us, I'm sure, a lot to think about. I'm looking to see if I don't think there's actually any questions in the Q&A yet, because I think people are processing your many, many different ideas and the things that you do.
Yeah, there's lots.
So I might start you off with a question because just in terms of, for example, even the EMR, getting back to real basics, you talked about, optimizing your EMR. You mentioned like smart phrases and macros, and I'm wondering if you could just talk a little bit about that if people aren't doing that. I think probably most people are familiar with templates and that kind of thing.
Yeah, so like in TELUS, we would use stamps. I think in Curo, it's macros, but when I write my note, I'll break it down in the assessment and plan into like assessment, conservative, medication, investigations and referrals and prevention. And I've got a little stamp for each common thing that we see. So when I'm in infectious, season, I've got my, here's what I told them about strep throat, because I tell everyone about strep throat that way. Here's what I told them about their kids' ears and eustachian tube dysfunction. Here's my standard script that I would give someone in after hours if they've got eustachian tube dysfunction. If we're talking prevention, I've got different prevention stamps based on age. But, to Ryan's point with an AI scribe, it's kind of changed that flow a little bit, because I find myself living more in an AI scribe, and I'm using the little directive assistants to just help my remote staff navigate and make sure that they can post a result and get that result handed off to my staff that's here in the office in London. I think I saw one question from Kevin, how exactly I have staff post from HRM to TELUS. So maybe I'll review that with him. So Kevin, what I do is I have a website we signed up for called ScribeHow. So ScribeHow essentially lets you record your workflows in your screen. So we've recorded workflows from TELUS and then removed all of the PHI because you can gray it out or blur it out. And I've shown the staff, this is what the HRM box looked like. This is Dr. Pepe's box. These are the Dr. Pepe results. This is what each result category is. So if it's a GI result, they say gastroenterology. If it's an upper endoscopy, it says EGDoscopy. And they double click it. And then what I've got them doing is actually taking the text, the impression and plan from that consult note, and then sending me a message. So they've already posted it into, let's say it's Eleanor's chart. Eleanor had a scope. They've posted the scope into her chart, and I can see EGDoscopy. It's linked to the posted note, and then I have a message with the summary of that note. I don't know if that makes sense, Kevin, but it's literally all the little tiny steps and clicks that we do. I've counted it. It's like 16 clicks to get a result posted and get the text out. I've delegated that so that when I look through my inbox, I don't look at HRM. I look at my test results, and all of my test results are there. Yeah, it's called the Clinic Line. I didn't actually even know they existed, but they're an interesting company. Yeah, it's a lot of clicks, and it was very painful doing it like 5 years in a row, and with little kids. I'm thinking, I measured my time, and it was about an hour a day posting results. So yeah, it's probably a unique thing to tell us, but there's all these little tiny inefficiencies. No concerns for outsourcing the data because they remote into an Amazon workstation here in Canada. So all the data residencies here, and the data doesn't flow anywhere else. But that's a thing where you have to talk to the company individually. That's just how I solve it, and I felt like it wasn't right to tell you how I solve it without telling you what company I use. So not an endorsement or don't go with them, just that you have to use your own discretion. But there's a lot of things we do in our day that are not medicine, I would say, Eleanor.
Absolutely. So a couple of questions down in the Q&A, and I think there's one more in the chat that I'll get to in a minute.
Okay. Yeah.
So how do you deal with the stuff in your inbox that you don't know what to do with? You know it's not urgent, but you're not quite sure what to do with it, so you just let it sit.
Oh, so painful. I mean, those are probably the worst. So I think the key is to try and not let them sit. Do you have an example? Is it just something that you're not familiar with, or like a diagnosis that you've never seen? Maybe just give us a little bit more context on that. Because there's some stuff that I don't want to answer because I know I have to call someone. It's going to be a really big, long, contentious call, and I just don't have the emotional energy to do it. And then there's other stuff where I don't know what it is. And now those I tend to push through to e-consult. So I'll find the appropriate specialty, and I'll be like, hey, neuroradiology, what is someone had a lipoma in their quadrigeminal foramina of unknown significance. So I sent that to NeuroRads. I'm like, what is that? And so at least you get an answer for the question that you don't know. But yeah.
Yeah, I think sometimes too, I found not where I'm not sure about, the diagnosis, like where you're using e-consult, but I went to another session where they also suggested sometimes those are ones where you do just need to book an appointment. If you're not really sure how to handle the message, maybe it's like you need to have another conversation and just book them in.
Yes, exactly. I'm trying to see what I can do without the appointment booking, but I agree. There's some times where you're like, I just need to see this face to face because I have no idea what they're describing, right?
Another question here, would love more details on how you implement specific filtering in the TELUS inbox.
Yep, for sure. I am going to see if I can get my TELUS instance kind of launched in the background. And then if I can open up my own chart, I can maybe screen share with you guys, and then I'll just do like a mock chart and I can show you that way. So with that, there is on the TELUS dashboard, what's called message subject summary in the bottom left-hand corner. And if you click it, you can actually set different subjects. And so once you've set the subjects, you can then actually send messages according to those subject summaries. It's something that I kind of stumbled on maybe 2-3 years ago. But it was really, really useful to do because it just prevents you from sending messages with like a very random subject heading.
Great, thanks, Dan. Actually, on the same, I guess along the same lines, you'd mentioned a hot and cold folder.
Yeah.
Is that the same idea, or could you elaborate that, or is that a different setting in the PSS?
It's kind of the same thing. It's just you want to make sure that everything that you're tagging has a very specific subject summary, because I think it's so easy to go, can you call this person and follow up? And that's the message subject that you send. And if they're trying to use any sort of filtering or organization, they can't see it, because then you're just giving them a list of like 30 messages and they've got to read each line. For my staff, because they've got all the individual boxes, it's like, okay, Jen, go in my prescription box, look at all the ones that are labeled limited use code, and send the fax to the pharmacy saying all those limited use codes have been listed as indefinite, but remind them they're indefinite and please keep applying the limited use code.
So is the tagging happening on both directions? When you're sending messages to your staff and when they're sending messages to you?
Yeah.
Yeah.
Yeah. Yeah. It's just a habit. So if I'm in TELUS now and you go to the bottom left-hand corner and press the little plus button, as you do that, it'll say along the bottom message subject summary. And then when you click the little I next to message subject summary, you can pick, there's like 30 or 40 different categories. They're not perfect, but they're pretty good. And they're there. I'm getting my TELUS thing open so I can show people the directive assistant.
Awesome. Yes, you've seen the next question. Can you go over how to use the directive assistant in more detail?
Yeah, it's honestly been kind of a game changer, because I realized as I was doing the work, and I'm sure you've seen this too, Eleanor and Ryan, like you're doing some of the same things over and over again. And you're like, can I just make this a little bit more streamlined? Now, question is, can I screen share off of here? I think so. Let me see. Okay.
Yeah, I think you should be able to.
Okay, I'm going to share my desktop and then I'm going to flip over. Hopefully it doesn't do anything weird. Okay, can you guys see my screen? You can see TELUS that I'm on?
Yeah.
Okay, awesome. So this guy is my directive assistant. So Jenny is our remote staff. Jen is our regular nursing staff. So for example, let's say Jenny posts a result of someone's elevated A1C. She goes, code new IGT, send a reminder message to do a repeat glucose in 12 months, and then notify patient. So then if we click finish, you'll see a bunch of things happen. So TELUS is a little slow. So it'll make sure that impaired glucose tolerance is coded, and then see this message over here, pre-diabetes directive. Please notify the patient their average blood sugar is greater than 6 but less than 6.5, which means they develop pre-diabetes and are at risk. I'm going to try and launch Ocean, and I'm going to see if I can do my standard messages. So we've kind of tied what we do in TELUS to what we do in Ocean. Are you guys still following along here? You can see everything?
Yep.
Okay. So pre-diabetes, I think we've got them listed as nursing directives. So I don't send these often enough, which is why I don't remember exactly everything that they're called, but let's look up diabetes. There you go. So we call them doctor suggestions. And this is what we tell people. Now my computer is kind of cutting it off, but this is an example of the message that we would send. And you can say sign up and click join now as an example. So then we send that message off to the patient, and then they know to join for Lifestyle RX. And the reason I know it's successful or not is that we'll get a message back saying, the person wants to join Lifestyle RX. Do you want to approve? And we say, yes, absolutely. Maybe I'll just quickly take a detour and I'll show you Lifestyle RX for those who haven't seen it. So this is Lifestyle RX. I often will just show people this in the office and I'll say they have programs for diabetes, but they have programs for a ton of stuff: excess weight, fatty liver, PCOS, MCI, hypertension, high cholesterol. So for all my patients who come in asking about Ozempic, I actually show them this first. I just had a lady who brought in her Manulife forms for Manjaro and Ozempic because she was getting her Ozempic through Felix, paying $300 a month. I said, I've already lost 20 pounds. Try this and see if you can actually lose a bit of weight. So what they do is I just walk them through this. I say, okay, so you go join now. I'm from Ontario. And if they're just overweight without prediabetes or diabetes, they click metabolic syndrome, pick your issues that you want help with, select your goals, tell them you're excited, put in your email, and then you'll get a report back. And when they put in their email address, Lifestyle RX reaches out. They get a set of labs from their team. They meet with a physician, and then they get 12 weeks of individual lifestyle coaching. So that's lifestyle in a nutshell. Okay, what else do we got? Other stuff
Amazing.
you want to see and tell us? We got lots.
Yeah, HRM inbox delegation, I guess. Question around delegation.
Yeah, so with that, for me, the HRM inbox delegation, people will go, well, you can't delegate your HRM inbox to a staff. And I would say, I'm not delegating the contents of the inbox. I'm delegating the process of clicking, posting, and moving it into the record. And I would love to show you guys how I actually do that, but I don't want to show someone's PHI. So we're not going to do that. But you can delegate someone clicking a box and saying post. That's okay. You just have to be the one to actually review and action it. Okay. Other questions, tell us wise, Eleanor, or what do you say?
Well, I think somebody just wanted to clarify that you're using Ocean to email the patient.
Mm-hmm.
Okay.
I am. Yeah. It works okay. It's not perfect, but it's all right. The other thing I've got like, for example, an uninsured note assistant. So someone's got, they're sick 01/01/2026, and they're going to be off for 2 weeks. And you just press finish. And then you get a sick note. Or someone needs, a note for compression stockings for their neck pain. There you go. So these are all simple ways that you can kind of reprogram the encounter assistant to help you and to actually make your life a little bit easier.
Amazing. Another question here was just around the use of SOPs and about how you implement them.
Yeah. So how I create, So in terms of implementation, it's really just about consistency. So when you make that standard operating procedure, you need to be consistent with it. So you can't say, oh, okay, we have an SOP, but in this case, we're not going to do it. If that is your standard operating procedure, then that is your standard operating procedure. And you need to stick with it. So my little guy just got home. One second. No, she's not. I'm just on a call. Can you go in the other room, Luca? Thank you. Yeah. Life of family medicine when you've got kids. Just coordinating everybody. It's like the guy on was it the BBC where his kids walked in the room? Yeah. My kids will probably do that at some point. So I'll apologize in advance for them, but they're fun. I think with the SOPs, the implementation really is not the hard part. The hard part with the SOPs is deciding on what your standard operating procedure is. For your patients with prediabetes, are you going to do the same thing across for everyone? And that's why I find prediabetes easy, because if it's 6 to 6.4, my old advice was to call them, give them some general advice around lifestyle counseling, but I really wasn't great at it. And now to have an option of something like Lifestyle RX to say, I know you don't have insurance coverage, you don't have benefits for a dietitian, you now get 12 weeks covered of lifestyle coaching is amazing. So that's why we've kind of implemented that as an SOP. Or another one is someone has low ferritin, but no anemia. How common is that? So for that one, my staff see that they have low ferritin. We send them a link, ferrous gluconate, take it in this way, take it with this, and then it's all in an email. So there's no questions around what were the instructions. We also send them the link to Heme Equity so they can look and see all the different iron supplements. If they want to get Ferromax, they can purchase Ferromax because it's more elemental iron with theoretical better absorption. And then my staff get a task in 3 or 6 months to repeat their ferritin and check it. Same with vitamin B12 deficiency. We noticed you're deficient in B12. Go get 1,000 mcgs of B12, take it daily, and we'll check it in 3 or 6 months. those are all things, but you have to decide as a clinician what's that going to be. And I don't know, Eleanor, if that resonates with you and your flow, or Ryan, if that resonates with your flow, but that's how I've kind of streamlined it, or tried to.
Yeah, I mean, I think it's good too to think about like what are the for you your own clinic, like what are the things that are, repeating all the time that you're really gonna it's gonna make a difference if you have an SOP. And
Yeah.
also it sounds like perhaps if you're starting practice, maybe pick one or two, you know,
Yeah, exactly.
and work with
These
that.
didn't show up overnight, right? I mean, this is 8 years of just snowballing and accumulating processes. Pick the ones that are most painful.
Yeah, excellent. Now, there's a question here about e-consult and how
Yeah.
it fits into your workflow. I would mention, I think Ryan posted in the chat, we actually have a session on e-consult coming up in March, a full session on it. But if you want to just touch on how you've been using it, which I think you did, that would be great.
Yeah, I like eConsult a lot. I think when I was early on in practice, I think someone also made a question about like fee for service physicians. I'm assuming they can bill eConsult. When we were early on income stabilization, I used eConsult all the time. I was like $16, $16, every little bit helped. And I would ask questions, not only of things that I didn't know, but sometimes I saw a kid with abdominal pain and I thought, okay, I'm going to do this and this and this, and here's my workup. I would actually send that workup to a friend of mine who's a pediatrician in the community and say, here's the story. Here's what I was going to do. Do you like my workup? Oh yeah, I like that, but I would also do this. Oh, why? Okay, because of this. Oh, okay. Now that's part of my. So I kind of use the consult very much for like a learning tool to help myself just make sure that my workups and management were okay. So I feel like I use it a little bit less now. I like it for reviewing really rare neuroradiology things that I don't know how often we should be following up fusiform aneurysm of the A2 ACA segment. That was one that I sent today. I'm like, what's the good advice? So NeuroRads is always helpful on that front. We had a baby that we did the regular 2-month vaccines on, and I've never seen this before, but their thighs turned bright red, both thighs, only from their crease to their knee. And it was red. I don't know if you guys have ever seen that, but it was kind of weird. And so we sent a photo of that to the allergy guys, and they were like, it's fine. We would recommend that you just proceed with regular vaccines. I was like, okay, do we give them Tylenol? They said, well, you could, but the Tylenol might impair the efficacy of giving the vaccine, which I have also never heard. So that's kind of an example of where eConsult adds value. The only part that is kind of annoying about eConsult is some of the data entry pieces in order to send the consult. I find a bit frustrating. Anywhere where I'm re-entering demographic data, I find is just a point of friction that at this point in my career is a little annoying.
Yeah. Thanks for that. Actually, I find with the e-consult, if you do it directly from PS through Ocean, you don't have to enter too much. But yeah.
Yeah, you're right. It's just crashed on me recently a bunch,
Ah,
and so I have emotions with it. It's just
all right.
yeah.
So, all right, we have 15 minutes. We have quite a few questions that are still there, so I'm
Okay,
going to
we'll tackle
jump
it.
through these.
Yeah.
There's a question about you sharing your templates.
Yeah. I I can share them, but I probably have to share my actual workflow in order to get value out of them. Which, if there's interest, I'm happy to come back and do. And people have asked me that before. I haven't gotten to a place where I'm sharing them yet because I want to make sure that they're good enough. I'm not sure that they're good enough for mainstream consumption.
Right. And that's completely understandable. If you ever get to that point, I'm sure there'll be some people that would be very happy to have a look at them.
Yeah.
There's a question here just around like the whole idea with fee for service and FIGs, where seeing the patient you get is how you get the most out of your
Yeah.
compensation.
Yeah.
Do you have, I mean, how would you don't work in that model, but just do you
How
have
would I
any
do it?
thoughts around delegation?
Yeah, for sure. I still think delegation is a very effective practice because the question is, do you want to bill a bunch of A001s for calling someone or reviewing a simple result and saying, hey, your X-ray is all normal, A001, or do you want to actually book longer visits that are KO37s, KO13s, KO33s with repeated counseling? It depends on who you are as a person. If you just want to have a bunch of quick appointments, then sure, don't delegate as much, do higher volumes and do many appointments. If you're someone who appreciates having a conversation, delegate off the stuff that doesn't really need a full conversation and have the longer counseling visit that you're patients will actually appreciate. I find the older I get, those are the visits that I really enjoy, when you kind of get that breakthrough and aha moment, not really diagnosing someone with strep. It's kind of easy, but anyways.
Yeah, that's good to think about it also from your personality and what kind of practice
Yeah.
you're looking for.
Yeah.
Question here, somebody's spending a long time to do notes at the end of the day. So any advice on tackling that?
Yeah, that was the first 6 years of my career until I got an AI scribe. And then I turned on the AI scribe and I have never, ever, ever looked back. And I used them when they were first coming out and they were awful. We had to do a lot of editing. They've come a very long way. So my advice is AI scribe, for sure. And I know a lot of people struggle with the trust and where's the data going and the PHI and all of those things. And sometimes we get worried on the security side of it. But truthfully, I was saying this to a friend of mine who's a professor today. Um, we don't use a lot of PHI in our conversations. I might say, "Hi, Eleanor, how are you? What's going on? Tell me what brings you in." Talk about an issue, but I don't talk about your date of birth, your health card number, your last name, your phone number. Like there's not a lot of actual identifiable PHI in them, and I find they're incredibly useful. For me, I use Scribeberry. I've used it for a long time. I was actually looking at how many dictations I've done on Scribeberry over the years, and I'm over, I think, 4,000. So it's pretty neat. But yeah,
It's amazing. And Ryan's mentioned an AI scribe that he uses, I think Nexus Pro or something.
sounds
So
cool.
yeah, there's a lot out there.
Yeah,
I've heard like it's also good to just try one out, see how it works for you, because some of them have like slightly different features and all the rest. So
yeah,
check them all out. A question about making assistants. I think
yeah.
around your directives assistants. How can people learn how to do that?
Okay. Let me show you guys quickly. Okay, can you guys see Telus again? All right, let's go. I think it's under editing custom forms or something like that. I can't remember offhand because I haven't done it in a while. It's never good to try and demo something in the middle of a talk, but humility, right? I'll just show you what I know.
I, yeah, I did see it. I think I thought it was under edit.
Under edit, okay.
Oh no, sorry, one over from there. Settings, under
Setting.
settings. Well, there's
Ah,
the
there you go.
edits.
You're the
Yeah,
best. Okay, teamwork. Family medicine is teamwork. So let's see if TELUS is going to cooperate. I am clicking on the box, but it's not letting me search the word directive. Maybe we have to scroll because it's TELUS. Okay, directive
well, we know
assistant
the first step now. You go to settings, edit custom
settings.
forms.
Then you go here. You can also make a new encounter assistant as an example. I'm just going to show you mine kind of behind the covers a little bit. So for example, code IGT. So what I've done is there's the caption. So the caption goes there. I've made it a checkbox. I've got it going to the note that gets generated here. And then I have it appending to the problem list. And then I associated a diagnosis code. And then I make it say IGT. And then for sending a reminder message, the reminder message goes here. It's going to send a message. It's going to go to JB, who's our nurse. It's going to say this to her in the message. And it's due 365 days later because we're going to repeat labs in a year. So this is how I've kind of hacked it. When we have them calculate the lipid risk, it goes to the decision aid for CVD. When we have it calculate your percentage risk, it generates a custom vital. And so those are a couple examples of how we do it.
Great. And that also sounds like that might be the kind of topic that if people are really interested in, put it in the feedback, and maybe it's like a session of its own.
Yeah,
Um, yeah,
that's its whole own thing. I wanted to give you guys a sense of how you manage the paperwork in the inbox because sometimes managing the inbox result requires having good outflow. And if I don't show you the outflow, you'll have no idea what I'm doing on the back end. So that's why we included it.
great. Question regarding, I'm not sure if you can't answer this one. Ryan also works with an Oscar inbox.
Yeah.
Any advice on how to deal with the Oscar inbox? I don't know how to do folders. If you don't know that, then I can turn things over to Ryan for that.
Ryan, question.
So in Oscar, you do have one main inbox, but you can actually stratify it based on just labs or anything else your staff puts in, like general documents. And there should also, I don't use HRM anymore, but there should probably also be an HRM tab. There used to be in my Oscar Pro predecessor Invicare. So if that was the question and you want to just knock off your labs because maybe they hit your inbox directly versus a document maybe staff set eyes on, you can just click on the labs and then it gives you all the labs to go through. If you have any other questions with that, you can just put those in the question or the chat and I can answer them in the chat actually.
Great. And then I think the next question, which SOP topics do you typically use? I think you referred to a couple of these, Dan.
Yeah.
The impaired glucose tolerance or prediabetes, low
Yeah.
iron.
Yeah, there's a bunch. Mammograms, colonoscopy, like redo colonoscopy in 5 years. Anything that you can think of where you go, I'm going to have to deal with this again. And you've dealt with it more than 3 times in your career is an SOP.
All right. Question about the website on the different irons. I think it's heme equity. We can look at that, or
Yeah.
equity heme. I'm
Yeah,
trying to remember
I think it's heme equity. They actually, when someone has iron deficiency anemia, they put the link in the lab posting. It's hemequity.ca.
Yeah.
It's kind of cool.
So yeah. Some questions around AI scribes, just in terms of a couple of people mentioning the wordiness or
Yeah.
that sometimes it takes a lot of editing time. Any thoughts or feedback or tips on that?
Yeah. So part of it is don't be too fussed if it doesn't sound exactly like your voice. I've had to adjust my style and kind of get comfortable with how it writes it. For the wordiness, I say write in point form, not long sentences. And if the note is too wordy, I just prompt it in Scribe. I say, make it more succinct. And I just kind of get sassy with the Scribe and it kind of corrects itself up. But I usually don't go in and directly edit it. And if it makes a spelling mistake and it calls me Dr. Puppy, then I just write Dr. Pepe. And then I just enter that and it actually corrects it all throughout the Scribe. And if it spells a specialist name wrong, I just spell the specialist name and say Dr. this, not Dr. that. And then I do it. But it's pretty minimal, to be honest. I really don't do a heck of a lot of it. So, yeah.
Great. Quick question. How do you direct staff to send blood work x-ray requisitions? Some of these sounds like they're part of your directives.
They're delayed messages is basically the bread and butter. So instead of sending the message right now, we say send this message in 90 days or send this message in 6 weeks. And that's how we make sure that they get it in 6 weeks.
And a question from the chat, just wondering when the lab sends lab results electronically and via paper, including results saying pending. You end up seeing the same 5 results for the same thing over a few days. Apart from asking the lab to send all electronically, any other solutions you've come across?
So even when they send it electronically, you will still get them multiple days in a row because I have that happen all the time where I get an A1C and then TSH and creatinine are pending. And that's why having my remote staff just post it is great because they send it to me. I look at it, not all the lab results are there. I archive it. And then the next day they resend me the whole thing and I archive it. So I've delegated that pain to someone else. Unfortunately, in all my years of practice, they've talked about fixing it 7 ways from Sunday. I've never seen it fixed. And I don't know that it's a great priority for the labs or OMD to fix it, even though it's on the list. It just doesn't seem like it's top priority. So I would say try and figure out a strategy where you don't actually action those partial labs until they're all back. And even if the patient calls and goes, oh, well, I saw a partial lab back, it's not all back and I can't call you till it's all back. That's kind of a boundary thing that I've set up with people. And that seems to be helpful. I don't know if that helps anyone, but that's how I think about it.
Yeah, and I mean, definitely making sure that you have called, for example, Life Labs and asked them to turn off pending, because I know we've had that issue too, and you can stop it being as frequent. There's also, you can send to HRM places that are sending you duplicates. You can tell them to stop paper. And maybe we'll post that in the resources when we send around the resources after this. There's an OMA website that has all of the places that you have to email to say stop the paper so you don't get 2 copies. All right, we got 4 minutes. How long do you allocate per day to manage inbox? Is inbox 0 possible? Do you only check it during one time? This person has trouble not checking it constantly.
Yeah, I also have trouble not checking it constantly. Inbox 0 is impossible. So just to say, it's not a real reality because the inbox is like laundry. The moment you put all your laundry away, someone comes by and puts a sock in the laundry. you've wrecked it. So inbox zero is impossible. And that comes from a perfectionist who used to take pictures of when my inbox was at zero at 6 o'clock at night. All it leads to is burnout and exhaustion, unrealistic expectations. So no one expects you to have an inbox of zero. And if they do, they're not paying us enough to have an inbox of zero. So do your best, do your job, look after everybody. If you want to set a specific time, I usually go in and try and clear mine throughout the day. I tend to not be able to clear it in that first 90 minutes. And even if I go home and I still have 5 or 10 things, it's okay because I've looked at all of them and I go, that's a tomorrow thing. And that's really a boundary and self compassion thing for yourself, which has taken me 8 years and a lot of humility and a lot of humbling experiences to say I'm not perfect and I cannot get everything done. So even though I show you all these magical systems and SOPs and stuff, I have struggled and cried and been frustrated and upset at this more times than I like to admit. And I think sometimes when you see people on webinars, you think they're like these magic humans and unicorns. I am not. I am like you, and I have asked all the questions you guys have asked. So you're on the path.
Great. We'll finish up with our last couple of questions because I know Dan has a tight 8 o'clock. He's got to get back to being a dad.
Yeah.
But there's just a few questions around the post dating of messages. So for things like repeat colonoscopies, et cetera, at a future date, do you set the reminders for yourself or staff or reach out to the patient to leave it to their responsibility? And then also if you're post dating things and it requires a signature, how do you manage that? Like if you
Yeah.
have a requisition.
So let's tackle a repeat colonoscopy thing. So what I typically do is I review a result like a scope note and it says send the patient back in 5 years. I send my nurse a message and I say, can you reorder a scope in 5 years? And then she sends a delayed message for herself in 5 years because I know I don't have the attention to detail. So I give that to my staff who are really anal with a good attention to detail. And Jen actually has all those tasks and then has it built into her schedule that on the first of every month, she has all the delayed tasks. She goes and clears up. So she kind of dreads that day, but that's also the day she knows all the tasks are there. So.
Well, thanks, Dan. And there was one question just around, I guess, around fee for service again and posting. If you ask somebody else to do that delegation, you're
Yeah.
just saying you just have to, you're sort of giving up that billing code and for other options.
Yeah.
Yeah.
It's realizing that we're more than just billing, and money and happiness comes from more than just money. So you have to decide what makes you happy and what gives you value. And that's understanding yourself as a person. But that's a whole other talk.
Excellent. Well, listen, Dan, we really appreciate that time that you took to come and giving us a lot to think about and some ideas that we can all take forward. All of us at all levels of career. I certainly learned a ton. And yeah, just thanks very much. We know it's a tricky time when you have young kids to make 7 to 8 work. So thanks again for that. And lots of thanks in the chat you'll see. And just a reminder to those people that did come, please do link to our evaluation and give us your feedback because we want to make this as useful as possible for you guys. So thanks again, Dan. Really appreciate it.
Good night, guys. Have a
Hope
great
everyone
night.
has a
Good
great
luck to
night.
everybody. Have a good week. Okay.
Take care. Bye.
Ciao, guys. Bye.